Hello, ladies and gentlemen. On behalf of ImagingBiz.com and Microsoft, I'd like to welcome you to the webcast entitled Radiology Efficiency, the Leading Edge. If you have questions at any time during the presentation, you may type your question into the question and answer box located at the bottom of the interface below the presentation. Questions will be collected and answered accordingly at the end of the presentation. If you are in need of technical assistance, please dial 1-800-303-0442 and reference confirmation number 30547580. This information is also listed on your confirmation email. Please note that this conference is being recorded. And now it is my pleasure to turn the program over to Cheryl Proval. Please go ahead.
Thank you. Hello and welcome to Radiology Efficiency, the Leading Edge, a webinar on an increasingly important subject, using clinical data to drive department effectiveness. Radiologists frequently operate in a clinical vacuum, interpreting studies with minimal clinical context. In fact, outside of RIS and PACS, radiologists often have no access to other local applications and information systems, even in the hospital setting. On the efficiency front, radiologists and department managers are called on to manage an increasing number of performance and operational metrics in the interest of maximum efficiency and quality. They seek flexible analytics tools to better understand performance. Tools definitely are needed to help radiologists deliver more unequivocal diagnoses and to assist department leaders in demonstrating their value to the overall enterprise. It's my pleasure to introduce our speakers today. Dr. Elliot Siegel is Professor and Vice Chair at the University of Maryland School of Medicine, Department of Diagnostic Radiology, as well as Chief of Radiology for the Veterans Affairs Maryland Healthcare System, both in Baltimore. I should add that he has done a good deal of the seminal research on radiology efficiency and workflow. Dr. Khan M. Siddiqui is Principal Program Manager, Health Solution Group, Microsoft Corporation, and a visiting associate professor of radiology at Johns Hopkins University School of Medicine in Baltimore, Maryland. I will now turn the program over to our distinguished speakers. Dr. Siddiqui?
Thank you very much. Good morning, folks, and welcome to the webinar. We will be talking about radiology efficiency and from an education point of view with Elliot Siegel, talking about how to handle and deal with it at a departmental level, and then what Microsoft is doing in this space. So if you think about in today's day and age, the pressure is mounting for changes to current healthcare delivery model. Their reimbursement model are being challenged. We have new regulations that are driving change, and we have to adjust to those changes. There's increased patient expectation for more engagement with the patients. There's obviously labor shortage, as well as organizations' ability to hire appropriate candidates, and then shifting affiliations between hospitals, imaging centers, and other healthcare entities with acquisitions and mergers. If you look at radiology workflow today, the really number of exams required to interpret per day is rising. The volume is going up, even though the reimbursement for it is going down. Complexity of exams is increasing. The tools that are required to get work done also seems to be increasing. You need image interpretation workstations. In some scenarios, you need specialized workstations. Then there are strengths and limitations to having unified workflow versus specialized segmented workflow for various specialties. The reporting systems are getting more and more integrated, but there are still areas where there's disconnect between them. And then this obviously has impact on the radiologist at the department level and eventually on patient outcomes. How does how does the interpretation process of radiologists or reporting actually affect patient outcome is also not that well understood, and the variability of report by radiologists also comes into a factor when you think about patient outcomes. So as departments and institutions are thinking about the investment considerations on improving radiology efficiency, departmental productivity, and patient outcomes, and even patient engagements, there are multiple choices a department may have. The department may be thinking about ripping and replacing existing systems. Often, there are incentives by the existing vendors to stay with the existing system. There is also health system impact. So, for example, if a hospital acquires or a health system acquires another hospital with a different system, and to really be efficient in radiology and provide cross-coverage of different institutions in a single network, it becomes complex with these multi-PACS environments. And then, how do you understand appropriate time to value for investment, and how do you measure that becomes a big question and challenge. Then there's always need for new functionalities. There are, advanced applications, computer-aided detection software, and other things needed to really understand, what are the new functionalities you need, and new requirements come on every day. So this leads to operational, challenges to integrate workflow, integrate software systems, and really the requirement or need to have better understanding of financial metrics around these changes becomes very crucial, and obviously affects clinical outcomes. So before I transition and let Elliot start his section of the presentation, let me ask a simple question. So the question that we're asking is, how frequently are the radiologists in the department accessing clinical data during the interpretation process? And by clinical data, I really mean anything beyond what they get with the order as part of the requisition or part of the small little field for reason for exam in the study. And I'm going to give 30 seconds for folks to answer this question. Okay, 5 more seconds. Okay, I'm going to push this to the slide, the results. So it looks like it is there, but only varies a lot. So 1/3 of folks say majority of the time they're accessing clinical data, and 2/3 of the folks are really either in critical cases or in small minority of cases. Great. Let me transition back to Elliot to talk about contextual clinical information at the point of diagnosis. Elliot?
Thanks, Con. And Con, it's really great to have you back here in my office at the VA. It's really nice working with you again. And thanks again for the invitation to be able to share some of my perspective and why I think this idea of contextual clinical information at the point of diagnosis is really so critically important. One of the things, as you know, Con, that we're in the process of doing is looking for a next generation PACS system here for the VA Maryland healthcare system and for our group of hospitals. And, we've had the PACS system ever since 1993. We were the first hospital that made the transition to filmless operation. And now that we've had the system for 18 years, we're asking ourselves the question of, as we look at getting a new system, and we start, and we've been talking with vendors and creating specifications and requirements, what are some of the things that we believe will be absolutely important? I don't know if we're going to have our next PACS system for another 18 years out to the year 2029, but even if we just have it for the next 5 to 10 years, it's important for us to identify what are the trends moving forward in the future, what are some of the lessons that we've learned, and what are some of the most critical things that we believe that we need. And so what I'm going to focus on is something that I think is critically important and something that has really changed surprisingly little since 1993 when we first started operation of our PACS system. And that's around the whole issue of trying to get information to the radiologist at the point where we are making a diagnosis. And I don't think that's really changed all that much from the way it was 25 years ago. So I'd just like to do a disclosure. We get research and other funding from many different vendors, and here's just a list of some of our research and funding sources for University of Maryland, where I work, and also the VA. Next, please. So I've been really interested, as you know, in issues related to productivity. How can we make the radiology department faster, more efficient, more effective? How can we measure what that impact is on patient care? And I've been really pleased in the last few years to see so many people and so many third-party vendors and some of the PACS providers and certainly Microsoft focusing on analytics and looking at productivity and allowing me as the head of the department, for example, to have a much better handle on some of those issues. So it's been great to have really good, precise information here at University of Maryland on report turnaround times, radiologist RVU productivity, study volume, referral patterns, who's referring patients to us, and how and what types of studies, and looking at trend analysis. And that's great, and I think that it's really important for our next generation PACS system. But there's been a really surprising small amount of work that's been done in what I might refer to as clinical analytics or clinical decision support, or getting information to me as the radiologist or to the clinician or to the technologist at the time that we are actually interacting with the patient. So next, please. So what I want to introduce is sort of this concept that I have of the automated resident and fellow, and why I really, really feel fortunate in an academic environment where I am currently at University of Maryland and at the VA Maryland healthcare system to have the opportunity to work with residents and fellows. And I realize that not everybody has that opportunity. And what I want to talk a little bit about is what I want my next generation PACS system to do to be able to automate some of those functions. So whether I'm in academics or whether I'm in private practice, I believe that this automated resident and fellow can actually significantly improve my productivity and include the quality of my patient care as well. So next slide, please. And so just to summarize, when I do image interpretation, given my clinical responsibilities and administrative and other responsibilities, I usually have at least one resident or fellow that I am reading out with. And this essentially aids patient care as well as my productivity. And so having that resident be able to spend time looking at the patient's electronic medical record or charts, having the possibility of being able to talk with the technologist about the study, and having the ability for this radiology resident or fellow to have looked at previous examinations and previous reports and collate all that information, synthesize it, and then be able to present that information to me really in a very clear, pithy, concise way is really a tremendous talent. And a resident or fellow that's able to do that well significantly improves my efficiency and my accuracy as well. And so having somebody who may have looked at the latest literature, having somebody who is up on the patient can be really great. And one of the things I'd love to see in a next generation PACS system is for the PACS and other information systems to be presented to me with that ability to synthesize what's really relevant and what's really important. And so whether or not I'm reading a PET-CT study, which I do, or whether it's an interventional case, or whether or not I'm doing interpretation of body MR, CT, etc., having that additional information for me really makes a significant difference. And that's the type of sort of analytic system and the type of system that can combine and amalgamate multiple different types of data for me to be able to do a better job. And so, one question is, are there analytic systems out there that could substitute for some or all the things that fellows actually do? And so what we want to do is actually provide you with a poll question, or, in just a second, okay. And so next, please. And so as far as the automated resident or fellow functionality, what are some of the things that I would like to have an automated system do? And those include the ability for review of information in the chart. I'd like it to look at old radiology and old pathology reports. It'd be great to have that information summarized for me. It would be really nice to have that at the time I'm doing image interpretation. Were there previous recommendations that were made? What are the results of pathology studies? Is this a follow-up examination? Were previous studies normal? And be able to have all that synthesized for me to be able to see and understand in just a few seconds. And then also what I want from this intelligent system is for it to provide context-specific and sensitive data that's integrated with my workstation workflow. So, for example, the information that I'd want when I'm reading a PET-CT study would be very different than the type of information I would need if I were reading out an ICU chest study or whether I was doing a body CT study. And so what I really want is for the system to understand me personally and what type of information I need, just as I'd train a resident or fellow to do that. And then I want it to be context-specific depending on the type of study, depending on the situation, and even depending on the patient's place of origin as far as whether or not it's a ER patient, whether it's seen to be a stat study, or whether it's a routine study. All of those things may affect the way the information is presented to me. And so in order to be able to achieve that level of information, I don't really have the information I need just from my PACS system. I don't have it on my speech recognition system. I don't have that information just on my electronic medical record, but I need to have all those systems be able to intercommunicate, and I need to have a mechanism where all those pieces of information from those different systems can all be put together for me to be able to evaluate. And so I either need to have a really tight integration with my electronic medical record, or I need to have some sort of system, like my resident and fellow, that can go out with the information in the electronic medical record, in the radiology information system, speech recognition, and other sources, and obtain that for me. And so as far as the innovation gap, we've seen tremendous advances in MR technology, CT technology. PACS systems have gotten so much better in the last 25 years. My ability and my productivity have improved, but arguably the radiology interpretation process has not evolved significantly. Even though the information that I get is presented to me digitally at the time that I interpret a study, the quality of the information I get, rule out atelectasis, rule out trauma, rule out pain, and some of the limited history that we get is really not very much better than it was 18 years ago when we first started. It hasn't improved, and this is really a major issue and a major deficiency. And as far as me as a radiologist providing added value locally at the hospital level and not really just interpreting the pixels, I think this is absolutely crucial. And for my next generation PACS system, I really want to completely change the way I have access to information so that I can provide much more added value with my image interpretation. And I'd like to sort of give you an example of that. So if you take a look at this image, this is a axial CT section through the mid portion of the abdomen. And for those of you who are radiologists, I'm sure you'll recognize right away that in this patient who presents with recurrent back pain, we're seeing mild dilatation of the right renal collecting system, and we're also seeing air within the mid portion of the right kidney. And so one of the questions as a radiologist is, how can I interpret this study, and what are the possibilities? Well, you know, if the only history is recurrent back pain, I don't know whether or not this is a patient who's had recurrent instrumentation, whether it be a nephrostomy or recent retrograde study, or I don't alternatively have any additional information to tell me whether or not this could be acute pyelonephritis. And emphysematous pyelonephritis, if that were the diagnosis, and that's what it did turn out to be in that patient, has a mortality rate of as high as 20%, so it would be a true surgical emergency. So as a radiologist, is this a true surgical and medical emergency, or alternatively, is this just an expected normal finding associated with a previous procedure? In many cases, I and other radiology colleagues really don't have that information, and it would be great to have supplemented the history of lower back pain with knowing that this was a diabetic patient, that there's an obstructing stone in the proximal right ureter, that the patient has a history of previous urinary tract infections, because it would have allowed me as a radiologist to have a much more focused, specific interpretation and know who to contact with urgent findings right away as well. So I think at this point we were going to do a poll, and I'd be really interested in how do your radiologists, or how do you as a radiologist, obtain clinical information? For me, when I need additional clinical information beyond what's in the history, then I have the potential to be able to go to multiple sources. I can get information from the order for the study, and as you saw, that patient with just a history of low back pain has really limited information. I can talk with the technologist. I can try and open up the electronic medical record, but that really can take a fair amount of time, and the electronic medical record is not very searchable, and you know, it could take me 15 minutes just to find some of the pertinent information. I could talk to the patient. That's, I think, advisable, but not always practical. Or, you know, in some cases, people just don't get information. So let's take a look and see what you all have as an experience as far as how you as radiologists or how your radiologists get clinical information. So it looks like it's all across the board. Interestingly, and I think it's really telling, that a third of the respondents don't even have any additional clinical information when interpreting a study, and 0% gets their information from the electronic medical record. And so I think that just shows how many barriers there are as I and you as radiologists or your radiologists are in the interpretation workflow, when, as Con said, we have pressures to try and be as efficient and productive as possible. It's just not practical to go into the electronic medical record, even for those such as we at University of Maryland and here at the VA having the electronic medical record. So I think it's really fascinating to see that, and you know, the information is obtained in 2/3 of the cases either from the order or from the technologist, from the people we polled, and I think that's probably reasonably representative. So, you know, what are some of the issues, and what are some of the ways that we can deal with that? So there has been, from a technical perspective, improvement in our ability to get information as we end up interfacing between the PACS system and the other information systems. 18 years ago, back in 1993, when our PACS system first came up, the PACS and the electronic medical record were completely disconnected. And then a few weeks later, we were able to at least integrate the system so that at the workflow, the radiologist didn't have to have the paper requisition, but had the information associated with the study. But as you all know, the information associated with the study can be very limited and can be only a small subset of what you actually need, and so people will go through the old reports and old studies and try and figure out that information. It's clearly not optimal, and in fact, I think it's really inexcusable how little information that so many of us get by with about patients, especially when that information is available in one or more electronic medical records. And so how do we get information to help us with the image interpretation? Well, this is just a picture of our electronic medical record at the VA Maryland healthcare system. And one of the problems is that although you can go to a problem list or to a summary, really the electronic medical record is still just a digital version of paper in many ways. Even though we're doing meaningful use and people are going digital, really these electronic medical records just have tabs just like a regular chart does. Here you can see problems and meds and orders. And so it's difficult to search through that information. And a nice summary sheet like this gives me some idea of the patient's problems and medications, but really without digging into problem lists and path reports and other things, it could take me quite a while to go through even the most sophisticated of today's electronic medical records. I really need a way to be able to summarize that information. And so it would be great to have something at my PACS workstation where I could have information that was presented to me, hyperlinks in the PACS system that could bring things up, such as patient's discharge summary, problem list, meds, lab values, etc. So I don't have to take my eyes off of the images and off of the PACS workstations. And I'd like to then have the system be smart enough so that it can have templates to give me context-specific information depending on the study, depending on the patient, and the urgency of the examination. So here's an example of a prototype clinical dashboard that I think would be helpful as far as an innovative way. And without going into details, because we don't really have time, just the idea of redesigning the dashboard so it doesn't just give me a list of studies to be read, but it gives me additional information as far as my image interpretation, what studies I have to do, and then the ability to call up lab studies and call up clinical information and everything else at my PACS workstation, in addition to the default information that gets presented. Next, please. So one of the things I want to be able to do is, at a glance, have the capability of being able to get a graphical sketch of a patient's radiologic history. And so this is courtesy of Dr. Gupta, who is at Massachusetts General. And this is something that I've been thinking about and working about for a while, but she and her colleagues have done a great job of this graphical sketch for a patient's history. And so you can see in January of 2000, patient had a large brain mass, a chest nodule, and if you take a look at May 2001, the brain mass has gotten smaller, the nodule remains the same, and if you look at March 2002, the brain mass is gone, nodule's still there, but it's been stable since January of 2000, so I'm much less worried about it. And now the patient's developed cardiac pathology in acute MI. And so I would suggest that in a matter of 2 or 3 seconds, just looking at those 3 pictures, that I can gather an incredible amount of information about the patient. And this is the type of display that I really want to have this automated system be able to create for me in my next generation PACS system. And so what type of information do I want to have the system present to me? Well, I'd like to have lab studies such as creatinine or AC1 that might be pertinent. Increasingly, I think 5, 10, 15 years from now, it won't only be for reading breast mammograms and looking for breast cancer, but we're going to increasingly want genomic and proteomic data for many different types of diagnoses. And we want those presented in an intelligent, easy-to-see way. I want to have patient information such as discharge summary, the operative note, and recent progress notes at my fingertips. A list of patient medications would be great, and information such as measurements and previous interpretations that I've had or we've had with CAD interpretations would be really useful. And then even to have an assessment of a priori probability of disease. For example, if I'm reading a ventilation perfusion study, having a clinical set of a priori algorithms that tell me what is the a priori likelihood clinically of this patient having a pulmonary embolism would help me in my image interpretation. Information from an injection protocol. Was there extravasation that I need to dictate? Can I get information from a smart contrast injector? Patient preparation for the study, protocoling information, previous studies at other institutions, ECG information, information provided by the patient to the technologist, results of a physical exam such as a thyroid examination that was performed, for example, in the nuclear medicine department. All of those would be really helpful for me. And so some of the wonderful things that I could do as far as uses of this information to improve speed and efficacy include I could use this information that I have clinically to automatically inform my PACS system about 2D and 3D hanging protocols, and knowing which previous and current studies to be able to retrieve based on that information. I could optimize image processing. If I knew that we were looking for a pneumothorax or life support lines, I could process an ICU chest radiograph accordingly, and also intelligent application of computer-aided detection or computer-aided diagnosis based on history. And so if I could actually have these things with this automated resident or fellow and integrate them between my PACS system and put together or amalgamate all the different information, I think I would be a much more effective physician as far as not only productivity and efficiency, but also quality of patient care. So, Khan, would you like to talk a little bit about some of the solutions that Microsoft has in order to try to give me what I'm looking for a next-generation PACS system?
Thanks, Elliot, and that was a wonderful overview of need for clinical data and analytics for the radiology and the radiology department. Folks, what I'm going to talk about now is what Microsoft is doing with our Amalga for PACS departmental solution to provide both operational intelligence as well as the clinical context of clinical data for radiologists and interpretation process, as we talked about. Before I go into this, let me also do a quick poll. And the question is, you will see it on the screen soon, is how would you categorize your department's use of analytics and business intelligence tools today? Are you guys using the BI tools? Is it mostly being used for financial tracking? What other metrics are you using in your department? Are you publishing scorecards for folks to be able to see and share them? Or you are really a data-driven organization and using all kinds of ways to understand operational efficiency? Let me give a few more seconds, and then let's push some results to the slide. So, interesting, again, it's all over the place. So a quarter of the folks really are data-driven today, and quarter are not using any BI tools at all, and rest of the half are really using for selective things. That's great. So let's really talk about our Amalga for PACS solution is really based on our Amalga Health Intelligence platform, which is really designed for streaming operational activities, both from a workflow point of view as well as operations point of view, provide coordinating care between different entities, different clinical sources, as well as providing engaging with patients directly or through an PHR portal such as HealthWall. So if you really think about radiology departments and what insights are needed, there are various things that I talked about earlier in the introduction of this talk, is all the reimbursement pressures that we are seeing with the Deficit Reduction Act and more cuts coming in, really requiring us to be operationally efficient as well as more being productive for radiologists also. So if you think of it, think of a time to do a scan is really a perishable commodity such as a hotel room would be. So if a hotel does not fill the room at night, there's no way they can collect that revenue. So how do you actually optimize the utilization of your scanner time and the space? And as you increase volume by really doing operational efficiency on the scanner, then you need also to make your radiologists more efficient unless you want to hire more radiologists to do the increased workload. And one of the operational efficiencies for radiologists really becomes to provide them the right clinical information so they can have much more confidence and faster interpretation time. And obviously, better reporting and better diagnosis and more concise diagnosis instead of reporting, a whole list of 10 differential diagnoses or saying it could be, nothing to a cancer and patient can die in a few minutes. Really doesn't help referring physicians. They would really like to get radiology information coming in very concise, very precise. almost like a lab value where it's really a binary answer for them, something needs to be done or not. And having that clinical context really provides radiologists better ability to provide much more concise diagnosis on what interpretation they're doing. And obviously all these combined lead to departmental profitability, and then be able to actually measure and show return on investment to all the investments you are making helps get the buy-in from the whole organization. So it's really our thought process around this was to really impact the overall care delivery model for a radiology department. And let's look a little deeper on what exactly are we doing. So if you see today, images go into packs, and what you get is a history of chest X-ray in a 55-year-old. You may not even get an African-American male, but you may get that information. And then all you have is images showing ill-defined mass. Maybe it's unchanged or slightly changed. And again, this X-ray may be within 3 months apart, and no change doesn't mean anything. So the answer really is inconclusive. Is it really pneumonia, or is it really some kind of cancer, or is it really just scarring from some old trauma he had or some other injury the patient had? But if you had relevant clinical data through a mammographer pack, for example, where you knew the patient was a smoker, you knew the patient had weight loss and has that chronic cough for a while, and the correct lab showing there's hemocritic, decrease in white cell, no change in white cell count, and actually hemocritic is dropping, then the idea and thought process of this being more of a lung cancer rather than a infection because of IV drug abuse, something like that, goes much less. So giving that precise diagnosis would really help also have a better relationship with your referring providers. What a mammographer pack does is brings in all the data from different imaging systems and EMRs, as well as patient data for problem list, medication, labs, other dictations, surgical reports, clinical notes, allergy information, all in unified view in context of the exam that is being interpreted by a radiologist. So here is an example of summary screen where each of these sections represents data element that showed unified single view in context of the imaging study being interpreted on the packs. As part of the same solution, there's also similar data available to the radiology operations folks, the radiology administrators, as well as financial folks, to really be able to then do analytics on top of radiology operational data, as well as for radiologists and chairman of the department who really want to understand more from an outcomes point of view, have this clinical data and imaging data together to do outcomes analysis, operational analysis, financial analysis. So mammographer packs provides both contextual insight for radiologists as part of the interpretation process, as well as for the whole department in the radiology, from operational intelligence, financial intelligence, as well as clinical intelligence. So just to summarize, the benefits really become for a director or executive of the department are to provide quality of care, gain insights into end-to-end outcomes. So for example, in today's day and age, we don't really know if we were doing post-contrast MR on patients who's had prior surgery is really helpful after 3 years or 5 years. How are you changing management? Same thing with pulmonary embolism. If you're talking about and diagnosing pulmonary embolism, are the clinicians actually acting on it? Are they actually changing the management, either if it's a positive study, putting patients on appropriate therapy, or if it's a negative study, to removing from appropriate therapy? And today, this kind of intelligence doesn't exist. Today, we don't have intelligence to understand the ambulatory status of a patient. So, for example, let's say there's an orthopedic clinic, and suddenly you're getting all these patients in wheelchairs, on stretchers, and you don't have the staff appropriately positioned in the different scanner rooms, and how do you, this may lead to inefficiencies in the utilization of room because now they have to take care of a patient that cannot move. Again, as we are seeing more and more regulatory requirements coming in, meaningful use and other things, there's a lot of pressure to provide data for JCO and other things, and as well as to provide data for compliance purposes. This obviously, having the insight on the financial operation of the department really leads to understanding of profitability or other efficiencies that are needed. From a radiologist point of view, it really is productivity to reduce workflow blockers. Majority of the time, or a lot of the time, you really don't need any clinical data. It's slam dunk diagnosis on the images, but it's those pretty frequent scenarios where it's not a clear diagnosis, and if you have the right information, you're able to quickly come to a conclusion instead of going on a fishing expedition in the electronic medical record or trying to call the physician to get that information. And obviously, this leads to improvement of care as well as effectiveness of interpretation. So this is my last slide, and I think we want to open now for some discussion and question and answer. We have about 17 minutes left. So if there's any questions. Let me go to the Q&A and see if we can. So I'll have Elliot also respond to these. So the first question is, you mentioned that the EMR isn't built for radiologists. What does the Amolga systems include specifically, and how is it templated to speed up the workflow? What's unique about it? So I guess the question is for me then. The Amolga system really is designed to bring the relevant information for the radiologist. So when you saw the patient summary screen that Elliot showed from the VA, the relevant information for radiologists really was the active problem list and the allergy section. The labs just showed what labs were ordered, and the rest of the things were appointment schedules and some of their billing and financial, like insurance type of information. What radiologists would really need would be to have the right information in the context of what is being looked at. A lot of our EMRs try to provide that summary, but without knowing if you're looking at a chest CT or a chest X-ray or a neuro MRI, or you're doing an angio procedure, what is the information you need? So for example, if I'm looking at a brain CT, I'm more interested in understanding if the patient is on Coumadin or not, so that if there's a bleed, I can understand the bleed is because of that. I need to understand if the patient is hypertensive or not, because hypertensive crisis can lead to that kind of a bleed. Whereas if I'm looking at a chest X-ray, I'm more interested in the smoking history, I'm more interested in the past surgical history, and things like that. So that's what the difference is between what Amalgam provides, is brings all this information in one place. And frequently there can be multi-EMR systems in an enterprise, and then how do you bring information from an outpatient and inpatient system in one place for radiologists also is some benefit from Amalgam. So I hope that answered the question.
Great. And then let me take a question that I think is a really good and interesting one. And that question is, do your radiologists have contemporaneous access to any clinical information outside the PACS risk while interpreting? And the answer to that is yes, we do, both at the University of Maryland and at the Baltimore VA Medical Center. For example, on my workstation, I have access to a complete electronic medical record. So the good news is that as a radiologist, when I'm doing image interpretation, I have access to the entire electronic medical record. I can review every single progress note that's been put in on the patient, all of the patient's pathology reports, old radiology reports, discharge summaries, medications, labs, etc. The bad news is that I have access to that incredible amount of information, but it's really unwieldy to access. First of all, I need to sign on to the electronic medical record, but it keeps trying to sign me off every few minutes because it sees that there's no activity. The other problem is once I'm even signed on to the electronic medical record, then ferreting out or finding the information that I need in the electronic medical record is a challenge. It's not really summarized the way I'd like to see it summarized. Another problem that we have is we have patients, for example, within the VA system, that come from other hospitals for imaging studies. And so there's not a combined list or a combined electronic medical record on those patients. And I don't have the capability of being able to, in one place, call up information on multiple electronic medical records, even though they're all electronic. And so what I'd really like to have, even though I do have full access, because of the fact that it's so incredibly unwieldy and takes so much time to go through that, I only use it in a small percentage of cases. So if I'm reading a PET CT, I would be much more likely to use it or have my resident and fellow use it. But even though I have contemporaneous access, it really is difficult to use. And that's why it's so important for me to have something that would be the equivalent of my resident or fellow that would allow me within the workflow, inside of the PAC system, to use a template to create my own view. Depending on what type of study it is, I would have essentially a summary of that information at the time I'm doing interpretation. And so just having an electronic medical record and even just having access to it as I'm doing image interpretation is not enough. What I need is for it to be seamlessly integrated into the workflow, and I need it to be smart enough to be able to give me the type of information when I need that information. So thanks for the question.
So the three questions are kind of related, so I'll take them together. So the first one is that we announced a partnership with Philips Eyesight and Amalga. I'll talk about that. And the related questions are, is Amalga intuitive at this point, and does it present info based on clinical context? And what does radiologists have to do to get data in Amalga, and where does data appear? So yes, we did sign partnership with Philips to provide contextual data as part of their eyesight packs, and it's one of the partners we're working with. We're not exclusive with them, and we could work with any system that is out there, but those are our first partners that we are doing this with. And in Philips Eyesight scenario, what happens is for each study, there's a tiny little Amalga icon on the screen, and when you click on it, it launches the clinical display of contextual data based on the study information, so based on what you are looking at and what has been defined for that type of information to shows up in the third monitor, and that's all configurable on you can use the canned templates that come with Amalga to show clinical information, or if you want to create custom views of data based on different types of clinical examination, that is also possible with Amalga. So it really is a contextual launch of it, and once you click on that icon, the clinical information shows up right away, and you don't have to do any more clicks after that, after the first launch. So it does support a single sign-on context launch up to the study level information, patient and study level information. So you don't have to sign in again, you don't have to select the patient again, you don't have to select the type of study again. It understands the information from the packs and launches it. So I hope I answered all those three questions. Next question, any more questions, please feel free to ask. So the next question is, what does IT department need to support with Amalga? And can my radiology IT support team handle it? So Amalga obviously as a whole itself has a variety of use cases from an IT perspective, and it can solve a lot of enterprise problems, but Amalga for PACS, which is what we're talking about as a departmental solution, is a subset of it. So from an IT department, enterprise IT department point of view, you would need access to feeds or database or some source of that clinical information that usually is under the purview of the IT department, and depending on how sophisticated your radiology support team is, they can absolutely handle it. So if it's just an HL7 feed from some kind of HL7 broker technology that you have, that you're pulling it in, and your IT department is able to connect all the stuff with Microsoft help, then that's a very easy thing to do. But if all the operations are with the enterprise IT, then you will need support from enterprise IT to enable that.
So Con, I've got a question.
Sure.
So let's say that I'm at a facility that does not currently have Amalga, and I want to have this capability, and I don't necessarily have a Philips Eyesight PACS, for example, because I know one of the questions mentioned them specifically. what are my options and what are some of the things that I can do to allow me to be able to have this level of functionality?
So you mean with Amalga or without Amalga?
So right now I don't have Amalga in my, I don't have the good fortune to have my hospital or facility that has Amalga, but I'm really interested in an intelligent system that can put together the information for my image interpretation. As a radiologist or member of a radiology department, what are some of the things that I can do to try and take advantage of the technology?
So without Amalga, it's really tough.
Okay.
Right, so you really
But
need...
there are PACS vendors that are starting to provide this functionality along with their PACS systems, or how is that working?
Because Amalga for PACS is really tied to the PACS system.
Yeah.
That's what you mean, right? So
and are there multiple PACS systems that have it, or is it a limited number at this point?
So we've only partnered, right now partnered with Philips Eyesight, but any PACS that will support single sign-on and contact sharing standards can be deployed with that also. Okay. So it's not really limited to that. But if a PACS does not support single sign-on and contact sharing, then that would require some more work. But our focus right now is on our Philips partners as well as any PACS vendor that supports single sign-on and contact sharing.
And do the majority of PACS vendors indeed support that? I mean, my understanding is that the majority do. Is that your understanding as well?
That is correct.
That's great.
So there's one more question about, I'm interested in integration of Amalga and HealthFall, and can you elaborate a bit on that? So it's Amalga and HealthFall integration really is not part of the Amalga for PACS offering that we're talking about today. It is part of our Amalga Enterprise application, and these functionality exists today, and a lot of our customers are using Amalga and HealthFall integration both to put data from Amalga to HealthFall for consumers and patients, and bring data back from HealthFall to Amalga. Just for folks who may have heard this for the first time, HealthFall is our patient health platform, which provides patients and consumers to own their respective data, medical image data or any other data. They can own it, and it's not owned by the enterprise. And the question really is asking is that how do we share data with the consumer or the patient through Amalga, and that is functionality available today through our Amalga for the enterprise solution. Is not part of the Amalga for PACS solution.
So it looks like our time is short. Maybe
5 more minutes left.
Time for one more question.
Yeah. So one question is, explain more about the analytics. What specific reports would help my department run better? Could I get built now without Amalga? So without Amalga, you would really need, first of all, to get data into some place. So even though a lot of enterprises are investing in data warehouses, the data warehouses do not today, most of them do not today cater for DICOM data. They don't even have DICOM data, so it's very difficult to do steady level or image level analytics on that. So with Amalga, we provide whole tools to be able to do reporting and different dashboards and different graphical interfaces, and these can be then published to a SharePoint portal for the whole of department to be able to access it. And within the SharePoint portal, the folks have capability to modify and filter around different results from an end user point of view. So the IT department can create the base set of tools, and then the end users can then play and modify them as their need arises. So we have 2 minutes left. Any other questions from anybody? I think if no more questions, then we'll end this webinar. Thank you for all who participated in the session, and you can go to our website, whatsnextinhealth.com/connected imaging to learn more about this, and contact us through that. Thank you very much.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.